The best textbook is a patient. First, we must understand our job well, and then only attempt to correct it.
Very different.
Because we will correct only what we know. So we must know it well to avoid disasters. That is what Hemant was mentioning. The analyzing the deformity is the most important part before attempting to correct it. So deformity is a deviation from normal anatomy. So that gives another point that all of us must be very well versed in normal anatomy. And we must differentiate between a contracture and deformity. Contracture is a deformity of a joint due to soft tissue. Whereas bony deformity is originating from the bone, and that can be in the limb length disparities, that is in the long axis, and it can be rotations. Rotation means rotation include angulation also. And then translation or in combination. Here, in this image, you can see that angulation is a rotation around a horizontal axis. There is a procurvatum deformity with the axis around that point. This is actually a rotation around that axis. Here you can see the varus deformity, which is in the anteroposterior axis. It's an rotation around that point. So conventionally, we call these two as angulations. And rotation is again an angulation which takes place around the vertical axis. So practically all these are angulations. There's nothing, or all these are rotations. So that gives an idea, no? We can combine all these things together in advanced deformity corrections. So for this analysis of any deformity, conventionally we have to take a full length standing patella forward X-ray hip to heel. But this happens only in majority of the cases. But some of the very, very difficult cases are not able to stand themselves. Then you have to modify your system. In some patients, the patella is already subluxated. You cannot keep the patella pointing forward. So there is always exception to the rule when you take the full length X-ray or whatever thing. Whatever you do, there is exception to the rule. But it's a general principle that we must take a full length hip to heel X-ray to calculate the mechanical axis of the lower limb. The mechanical axis is a line from the center of the femoral head to the center of the angle plafond. So that is the mechanical axis. Normally it passes through the center of the knee or just medial to it. It gets deviated when you have a deformity anyway. But many of the cases where they have a deformity of the upper end of the femur and the distal end of the tibia, you can have a mechanical axis which is going through the center of the knee joint. For example, in a coxa vara, sometimes you may not see a mechanical axis deviation. Normally, that is a mechanical axis deviation. The mechanical axis deviation, or MAD, is a perpendicular distance. How do you measure that? It is not from the mini film, the real-time measurement of perpendicular distance from the mechanical axis to the center of the knee joint. Normally, it is 0 to 16 millimeter medial. Now, alignment. Alignment is an important consideration, not only for deformity correction, but important for arthroplasties and fracture management. All of us are very familiar, no? Whenever you do the replacement of your tire, you always go for an alignment check. So alignment is important for anyone whenever you do a joint replacement. And it's very, very important that we do not create a new deformity while correcting a deformity. So that is the importance of planning, which was clearly mentioned by Hemant earlier. So look at this young man who came to me with the instability of the right knee joint. You can see a foot drop spin at the back. The limb is looking very, very straight. That was his full length X-ray. That was his knee joint axis. It is oblique. The real issue was he had a distal femur valgus, which was corrected in the proximal tibia acutely and fixed like this. And in the process, he developed a discount of foot drop because an acute correction of the valgus into varus stretched the peroneal nerve and developed a foot drop. So now he has to undergo a femur correction as well as a tibial correction. And all of us must be remembering an old dictum, correct all valgus in the femur and all varus in the tibia, which is not correct in in at least some other cases, not in all cases. Generally, it is okay, but always take a pinch of salt. So he is a victim of the dictum. You can see a tibial valgus, because the dictum says all valgus has to be corrected in the femur. So he had a tibial valgus, but was corrected in the femur. And the full knee joint was completely damaged within 10 years. See, his alignment is perfect. Even with alignment, so this resulted in malorientation, and malorientation can also damage the joint. This is another victim of the dictum. He had a femur varus, which was corrected in the tibia. And this fellow developed a lateral compartment arthritis of the knee joint. He was advised a total knee replacement at the age of 50 years. That is the mechanical axis. When you look at it, you can see the femur is deformed. And tibia is also deformed. So it was a very complicating situation there. Then, as Hemant said, we stick on to the basic principles. Draw the hip joint orientation line, draw the distal femur line, and draw the femur mechanical axis. LDFA and LPFAs are normal. So though there is a diaphyseal deformity in the femur, there was a compensatory deformity correction on either sides, and the femur ultimately falls in the right position. And you can see the iatrogenic tibial deformity alone has to be corrected. So that was again, he had a childhood myelinated femur shaft, looking like a crooked femur but well aligned. Nature, the great surgeon, has corrected the femur deformity at both ends. And the iatrogenic genu valgus was not being corrected by the nature and resulted in lateral compartment arthritis. And he was advised total knee replacement. So this is how I corrected it. I just made it straight. You can see the lateral compartment is much better, and he can even squat on the floor. This was very, very interesting X-ray. Okay, McMurray osteotomy on a 13 or 14-year-old girl. She developed McMurray osteotomy, I think, after many surgeries, and ectofemur has healed after McMurray osteotomy. She was happy with it, living with it, and developed knee pain at the age of 35 years. See, an innocent-looking knee, perfect knee at 35 years. She had knee pain at this time. And I saw her at 53 years. See, by the time the lateral compartment is completely damaged. See that the mechanical axis is shifted like this. This was how she was walking. That is a full-length X-ray. The lateral compartment is completely gone. So malalignment test is very, very important. And you must know the normal values. You must know how to do the normal alignment and orientations. Because once you know the normal, then you will be familiar with mal alignment and mal orientation. Now look at this girl. Can anyone say what deformity is this? Here the heel is looking forward anteriorly. The foot is backward. There seems to be a rotation in the leg. And there's a hip flexion contracture. And some sort of very complicated one. And this was the X-ray I got. And this X-ray shows the neck. This is the X-ray they put the femur, knee with hip. You can see lateral view in the AP. And you can see the fibula on the medial side. So the X-ray, we are only as good as our X-rays. If you don't get a good X-ray, you cannot analyze any of the issues. So our analysis becomes bad and results become bad. So that is a very important point, how to take a good X-ray. And the difference between the best and the worst analysis or result is a good X-ray. So for this girl, with this X-ray, I cannot do anything. So technicians are trained to take X-rays of normal people in anatomical positions. When anatomy is distorted, we have to go to the X-ray room and help the technician to get a good X-ray, because ultimately the X-ray is for us, not for the technician. In most complex deformities, as Hemant was mentioning, there is a primary deformity, that is the real deformity, and a compensatory, the secondary compensatory deformity, which may be correctable, which may not be correctable sometimes. And that was made by the patient as a compensation for the primary for walking. So how to find it out? As again, Hemant mentioned, we need there's nothing to substitute a detailed clinical examination. And that is the only key. When you are in trouble, look at all the identifiable anatomical landmarks of the limb. You can feel the anterior scapular spine, try to feel the GT, try to feel the knee joint axis, knee movements, feel the fibula head, and feel the medial malleolus, lateral malleolus. And try to place all this in the right position. And also don't forget about patella. For this girl, I just tried to examine her. I felt the medial malleolus and trying to see the knee joint range of movements. And I felt the patella on my index. And I tried to keep the patella to the floor. And that is the knee range of movements. And see, that is adduction, abduction of the hip joint. And that is how it is, the patella pointing forward. And this was how she was compensating. So it was looking complicated only because of the compensation by the patient. Otherwise, see, here again, in this image, you can see how her knee axis movement is. So can you take a standing X-ray for this girl? She is not even able to stand. Now I took her for an X-ray and felt the patella pointing forward, facing to the roof, and got her X-ray. So it was an extreme femur valgus. You can see the proximal mechanical axis or the anatomical axis and the distal axis. It is not crossing anywhere in the bone or in the limb or even in the floor to reaching far below the floor. So I had to draw the green line, that's the middle line. And she had a 105 degrees of the distal femur valgus and 65 degrees of the middle femur valgus, totaling about 170 degrees of valgus. So there are two coras. I need to do a osteotomy at this level. I need to do an osteotomy at that level and correct it. So here you can see I cannot pass a reference wire. Reference wire will be like this. I am not able to pass a reference wire. I am not able to do a IT band release. I am not able to do a peroneal nerve release because I cannot even put my finger in between these two. Even you can see this femur, the tibia was going to that side because it was supposed to go like this. The soft tissue was pushing it medially. So that is the real deformity there. What are the concerns here? We have no idea where the neurovascular structures are. I have done a Doppler and marked it with a pen, and how to retain it till the end of the surgery. To put wires and pins from medial side. I cannot put from lateral side, all from medial side. And how to do osteotomy from medial side, because there is no entry from the lateral side. Can I do a peroneal nerve release? Can I do a IT band release? How to make a frame? How to put the hinges and distractors? So all these problems can be solved when you are relaxed and thinking about it. It may take some time, but still it is quite possible. So whenever I need to control a bone segment slowly over a longer period in various planes, I resort to Elizabeth. She had about good range of knee movements, but I warned her she may not get much movements and may need a corticoplasty later. So they have to accept it. There's no other way. The magic of illusory fixator is I can make or we all can make a replica of the underlying bone deformity. This is the replica of the deformity. This is the femur axis. This is the tibial axis. And you can see one core, second core. So that is the frame. And the main issue was how to retain this line. This is the femoral artery line. I can do one osteotomy here, this other osteotomy at this level. So how to retain this line during surgery? As you prepare, the whole thing will go. Then my daughter told me, you can just apply henna over there. That will stay for 2 weeks. A 5 rupees henna, I applied on that, and she was happy. I could do the surgery. That was the frame, and all problems can be tackled well. I did the osteotomy there and distal osteotomy. You can see the cut only from medial side. I don't want to keep any wire on this side. And you can see the shank screws there. There's another shank screw there. Distally on the tibia, we have only 2 shank screws. Middle, I have 2 shank screws. And on the tibia. And as the frame, you can see these are all half rings. And this is the one distractor there. This is the other distractor. As it comes out, I have added all the other half rings in between. So you can see it is coming out. I've added more rings. Still more coming. You can see one more ring has been added. And distraction continues. And it becomes straight. So from there to here, and that is the result. So it was not a smooth ride. It took many, many sleepless nights, but still it is doable. This was how she was walking earlier. This was how she was walking after 6 weeks of removal of the frame. She had some 30 degrees movement on the knee and was not willing for a corticoplasty. She got married and has 2 children now. Shamsul, do we stop here and discuss it?
Yes, sir, we can, sir.
Or we'll finish the presentation.
So if you can stop this here and discuss, and you can take another case, or you can read both the cases and then discuss, sir. You can finish and discuss, sir.
We'll finish it.
Yeah.
Okay. Yeah, now we go on to that is frontal plane deformities. You can have frontal plane deformity, varus valgus, and bowing deformities in the femur or even the tibia. So he was actually referred to me for HTU. He had a frontal plane varus deformity and a limited knee range of movements. This was his full-length X-ray. You can see he's having a distal femur varus and a proximal tibial varus, limb-length discrepancy of about 3 centimeters, and quadriceps adhesions. So as an overall treatment, you have to treat all these issues. You cannot manage this one just by a HTU. So wherever I can get a safe acute correction, I prefer LCPs or interlocking nails over any illusion. So here, the femur, I decided to do a acute correction, a quadriceps plasty. From there, I got flexion like this. and fix the distal femur by LCP. In the tibia, I decided, you can see that suture marking there. In the tibia, I decided to go for illusor. Wherever I can't get a safe acute correction or I need lengthening, I prefer illusor over an implant. So here, and it's easy in the tibia, I did the osteotomy there and lengthening. That is the femur implant. You can see that lengthening has been consolidated. About 3 centimeters has been lengthened. And from there, he can stand straight. He is an architect professor. His architect has been corrected well. So this is a bilateral, you can see the full length X-ray. There is a diaphyseal deformity in the femur. There is a knee joint deformity. There is a tibial deformity. This is the mechanical axis shift. So all these things together. So I did the femur correction by nail and the tibial correction by illusor. This is after full correction. Whereas this girl came to be for illusor correction. She had distal femur valgus. So I don't have to do a distal femur valgus by illusor. I just plan like this, distal femur osteotomy and plating. So this was how before and after. That was how I just played. I didn't do, in such cases, I don't do even a wedge removal, just osteotomy and fixity automatically comes. And here you can see, here the distal pin is parallel to the knee joint. I got reasonably good correction. Here you can see it is not perfectly parallel. I have to keep the plate little off. So this man came to me because no girl was ready to marry him. He had a very complex deformity of the foot, knee, and hip. So when you see all these complex deformity, that means we are missing something else. It is not this deformity. This is not the real deformity. As Hemant was mentioning, there was a secondary compensatory deformity here because the patient has to walk with the foot on the floor. So he is doing so many tricks in his body. The real deformity was this. Bilateral, can we take a standing X-ray for this boy? It's impossible to take a full length X-ray standing. So I took multiple films and X-ray like this. So that is the mechanical axis. And he had a distal femur joint valgus and intra-articular deformity and extra-articular tibial deformity. So I did, this was a case long back, I did all illusor. The femur also I did illusor, but that was acute correction. And this is the tibial correction. This is before and after. So this is a bilateral bow leg deformity. You can see the mechanical axis going here. This is a proximal femur mechanical axis, distal femur mechanical axis. This is a resolution cora. So I decided to do one osteotomy for the femur, resolution cora. Whereas tibia, I want to maintain this anatomical axis also. So I draw the middle line and one osteotomy there, another osteotomy here, one osteotomy, two osteotomies for the tibia and one osteotomy for the femur. Because more osteotomy means more headache. If I am planning for two osteotomies in the femur, then I will have more headaches. In tibia, I can manage the headache. So I did that. This was the pre-assembly, which was fixed onto the femur. Did the osteotomy there. This on the tibia, you can see the two distractors and one corticotomy for femur, two for the tibia, and these are the distractors. Before and after. See, it is fully corrected now without losing any function. Now we'll go on to the sagittal plane deformities. This is a stiff nodule with the sclerotic bone ends. It looks like two knee joints, and there's a 6 centimeters of limb length disparity. All sclerotic bones are not bad bones, except you can see a small tiny sequestrum. But when there is no soft tissue problem there, patient is happy, no discharging sinus, I'm not going to bother about this tiny sequestrum. So limb length disparity can also be, I can use this as a corticotomy. I'm using that as a corticotomy at a lower space So no plan for opening. I put a frame like this. This is a distractor because it is touching almost each other. We have to modify putting distractors, and that is how the distractors are working. And after full correction of the deformity, this is his function before and after. He can squat, all the sclerotic bone has completely disappeared. This is a step knee. You can see a knee joint and a step here. What is this deformity? It's a sagittal plane recurvatum deformity. So this was the magnitude of the deformity. So I have to do an osteotomy here and bring it here. So osteotomy at this cora level is impossible because this is a tibial tuberosity. So I need to do an osteotomy at this level. So that means it becomes a osteotomy rule 2 as mentioned by in the deformity planning by Hemant. So osteotomy rule 2. So this is what I did. She had a limb length disparity of that much. So 2 level, 1 level limb lengthening here and deformity correction there plus lengthening. So this was the frame looking like. The hinge is at that point. This is the osteotomy level. So you can see the osteotomy, it got translated. And ultimately it got remodeled very well. You can see the regenerate going on both sides and before and after. Now, axial plane rotations and translation generally I resolve to SUV corrections. Nowadays I don't do with the ring fixators. So look at a very rare case of popliteal pterygium syndrome on a 6-year-old girl who underwent soft tissue release and just elsewhere for correction of her FFD. You can see that was her sciatic nerve and sciatic nerve was looking there. So initially I was not very well versed with anatomy. So I started exploring all these cases. So while exploration I found after removal of that anomalous muscle called calcaneoischiadicus, that's a muscle band coming from ischial tuberosity, it goes to the tendo-Achilles and calcaneum. So I exercised that muscles. Within that muscle there was a sciatic nerve. You can see the sciatic nerve there. So with that movement, I cannot get much of movement, maybe at 10 degrees of movements. So even after extensive soft tissue release, only a jog of improvement was there in the FFD. So I stopped doing exploration in further 2 cases I did it, then I stopped doing it. So challenge is the short sciatic nerve under the skin as a bowstring. To correct FFD, we must lengthen the sciatic nerve. We do not have a technology for sciatic nerve lengthening. Except Elizaro, we does it slowly and at the same time it realigns the knee joint holes. So this was the frame looking like. Here we can see the center board medially and laterally because I am not able to keep the full ring here. So to get that much of flexion, you have to be 2 half rings. And this is how it was correcting. And this is an extension and flexion. I put the frame there and these half rings, because if you just imagine if you have this full ring, then you will not be able to put that ring. So it is easy now, you can distract it here. So as it comes out, so that is the cora. That is the place where the sciatic nerve was lying. While distracting, you take the distance from the hinge to the distractor, divide by distance from the hinge to the sciatic nerve. So this, in fact, all the lengthening is depending on the sciatic nerve. 1 millimeter for the sciatic nerve, you plan it and lengthen it. At the same time, you try to keep a physial hinge, physial wire. You can see this is an Augmentation wire system adapted to the hinge. So I put augmentation wire into the epiphysis. So this is how it was coming out. And as it comes out, I added more half rings and the distractors has been changed. So I got the full correction like that. And that is how even hyperextension. I got full lengthening of the sciatic nerve. That is after removal of the frame on long-term bracing. Before and after, she has full extension, but there's a lag there. Now going into oblique plane deformity, where you can see the deformity both in AP and lateral. So this is actually an oblique plane, not a biplanar deformity. You find out the plane of deformity based on your oblique plane planning and keep appropriate hinge. You can see one hinge here on anteromedial side, and here is the posterolateral side. So this is the oblique hinge and that's the distract. This is after correction. You can completely correct it just in one go. You can correct all the deformities together. That is its function. Before, this is after, it is fully aligned. You cannot even find out which leg was fractured. Now something very complex, that doesn't fit anywhere. Look at this girl. I had that deformity correction her during this period, but later on I lost her follow-up. She came to me when she was a final year, fourth year MBBS student. She had a liminal disparity of about 12 centimeters. There was a valgus external rotation deformity for her and very limited knee range of movement, like 30 degrees. So 36-degree valgus, 30-degree external rotation, 12 centimeters liminal disparity, and only 30 degrees of knee range of movement. So I don't want to do any femur frame on her. So I have to save the 30 degrees of knee range of movement. Now, to preserve her knee range of movement, I must avoid a frame on her femur. As Hemant was mentioning, I don't like frame her in the femur. So I have to correct the valgus and external rotation without bone loss. I don't want to take any segment of bone out because I have to save maximum bone length. And still I have to fix it with the LC. And I have to correct the LLD in the tibia. So how to do the valgus, 36-degree valgus correction and external rotation deformity without removal of any wedges? So I started doing work with my bananas. So I cut one banana like this. You can see this is the anterior side. I just marked a toothpick for anterior, put a toothpick for posterior. I made a 90-degree deformity and see how, and put a toothpick for the hinge. Because this is now having 90-degree deformity and 180-degree rotations. Is it possible to correct it without removal of any hinge? See, the posterior part comes anteriorly, and I can correct all the deformities. That is 90-degree, varus, and rotations, 180-degree rotations can be corrected easily without removing any bone. If I can do that on that bone model, why not I try on the another banana? I took banana with the same angle because plenty of bananas are available. And I marked the rotations, 30-degree varus and 30-degree external rotation, and calculated it's a complex calculation, calculated the axis and converted into an oblique plane, did the osteotomy, and that was the hinge. So this was one plane. This is, you can see, in a 30-degree rotations. So I put the toothpick to find out that, the real plane. And I could correct both. I could align it, and rotations has been corrected now, and I can do a lock-in plate. So I found I can do that 30-degree varus and 30-degree external rotation on a banana. If I can do it on a banana, why not I do it on a femur? So I did it on the femur, same, and fixed with a locking plate, and the tibial correction has been done on the. So I saved a lot of bone and corrected on the tibia, and that was the final correction, looking like this was the final healing. This was how she was walking. Now this is a 4-year-old boy with a very strange deformity of both lower limbs. It doesn't look that bad there, but this X-ray was very confusing. You can see that it was coming like this, and there are a lot of other complications. It was a sad story of bilateral traumatic amputation which was re-implanted. It was like this. So they re-implanted it. Most probably they must have done the femoral artery graft, but the femur, the thigh part, when you do a femoral artery repair, the thigh part has no blood supply from the femoral artery. It must get it from the profunda femoris. Probably that is not repaired, and the distal femur went in for AVN. And that is why the distal femur was like this. The femoral condyle was a little bit different, and that is the reason for the AVN. And anyway, the limb is saved. That was how the limb was looking like. I could not feel femoral artery. I don't know what is the status citing now, because it is fully equal. Some toe movement was there. Femoral condyle, I could not find it out, and even patella was very difficult to find. So problems everywhere. Anatomy was completely distorted. Where is the femoral artery? The posterior tibial and dorsalis pedis was felt. Nerves, I have no idea and how to do a corticotomy. I took a 3D CT and I didn't go for a printing. So this was the image I got. So you can see how it was moving. But the femoral condyle was, as you said, it was completely dysplastic. There is no posterior part. Probably, and the CT report was a stiff non-union like. There was a non-union in the CT. That was the shape of the bone. And now, the femoral was dysplastic, post-AVN, patella was very small, CT was showing a non-union. And there was a femoral shortening also. So left side, there's a tibial shortening with the talipes equinovarus deformity like. So I took the printout and superimposed. You can see the deformity here, an extension deformity, and the equal amount of flexion contraction. So there's a hidden patella there and an equinus deformity. So you have to correct this, and there was a varus deformity that has to be corrected, and the flexion has to be corrected, and the equinus has to be corrected. So this was how it was looking. I have to do an osteotomy at this level, because partly it is healed here. I have to do an osteotomy. So this was the hinge looking like, the frame looking like. So the frame to correct recurvatum, varus, rotation and shortening at femur all together. A complex frame, the femoral osteotomy from the back, where the apex, knee FFD correction, and the ankle equinus correction. Slow correction at 3 levels after 5 days. So it started coming back, coming to normal position. So I did it on the other side also. So after the correction, he is walking with the frame. After frame removal, for the first time he is walking on his feet. So this was a master case. You can see he came to correct the limb length disparity. It was a very snake leg looking leg. The foot was deformed with a complex deformity there. This was X-ray looking leg. This is not only of the tibia. The fibula was healing with the proximal tibia. It was already operated. And here we can see the fibula. This is not healed. A complex multiplanar deformity by fibula and limb length disparity due to childhood infection. So with Ilizaro, we can play with it. We have total freedom. So I planned it like this. Proximal axis. Then I came to the fibula. One cora there. Another cora here. So I tried to correct it like this. So from where the tibia starts, here it goes to the fibula and the fibular deformity correction. At the end of the deformity correction, I translated the distal tibia after one osteotomy there to the proximal tibia for the fibula. Yeah, this was the frame looking like a very strange frame on the job. Started correcting. That is how I got the length back. And some deformity, you can see the heel is in valgus. So if I try to correct more, then foot will create more, because this is already the joint, Subtalar joint was already in valgus. So I'm not able to correct more. So I did only that much. The foot is plantigrade and this varus was accepted. So before and after. So as a first step, let us understand it well and then only attempt to correct it. We will only correct what we know. So spend some time to know it well, to study it well, plan it well, and nothing is impossible. Thank you.